back Dr. Lauren Castleberry, who's from the University of South Carolina at Columbia, and she's going to talk to us about vaginitis.
Good afternoon. Good to see you guys again. Did you enjoy your day yesterday? Afterwards? Good. So this is not a topic that I'm as huge of a fan of as I was on yesterday's abnormal uterine bleeding, but it's definitely an interesting one. And for those of us who work in a female clinic of any sort, it's likely to be the most common complaint that you will ever hear. And first off, I, again, don't have any disclosures to reveal. We're going to go over the normal vaginal environment and review some of the most common causes of vaginitis and how to diagnose them. I'm going to leave some of those that are less likely to be seen or a smaller percentage mostly out, or just say a simple word about them. We're going to go over treatment options for both normal and complicated cases, and then mention some other considerations, and then go over a few cases themselves. So, as for the most common causes, they're going to be BV or bacterial vaginosis, yeast or candidiasis, and trichomonas. And bacterial vaginosis encompasses the most of those, roughly up to 50%. And total, all three of these will encompass about 70 to 90% of all complaints of vaginitis that you see inside the office setting. Of those that are not going to be one of those top three, you're going to see atrophic vaginitis as one. Other outer vulvar dermatologic conditions encompassing others. Vulvodynia is a small percentage. And then others can be a whole host of interesting things, among of which include foreign bodies. So we're all, well, hopefully we haven't all had to deal with the retained tampon, but that's probably the most common of the retained foreign bodies, although we've certainly seen many other things like Snickers wrappers and all sorts of other stuff inside. So sometimes you have to remind the patients that it's not their pocketbook and they need to leave things out of there unless it otherwise has a need to be in there. So as for young and old vaginas, we all know that it's a lack of estrogen that's the similarity between both of them. But a lack of estrogen isn't just going to cause hot flashes for the older patient or for the young patient who hasn't quite yet reached that stage of life. The prepubertal and postmenopausal vaginas are similar in that they both have a very thin epithelium, and that's from a lack of estrogen. The pH is elevated to over 4.7, and I'll go into why that is on the next slide. But normal flora here is also going to include both skin and fecal flora, and that's just normal for them. In the reproductive age vagina, you have the presence of estrogen, which is going to increase the glycogen content in the cells, and that in turn leads to vaginal colonization by the bacteria lactobacillus. The lactobacillus there is going to increase acid production, and that is what drives the pH to less than 4.7, or a very acidic environment. And normal flora here is very heterogeneous and consists of Gardnerella, which we all know we used to attribute to solely BV, but it's not really, as I'll go into in a little bit. E. coli, group B strep, mycoplasma, and even Candida albicans. A lot of people, when they see that pop up on a pap smear, they want to treat the patient for a yeast infection, but you don't necessarily have to, because that very well may just be one of the colonizing flora that's inside their vagina and not symptomatic at all. So just because you see that there doesn't necessarily mean that you have an infection and or need to treat it. So when you start off evaluating the patient with vaginal discharge, you want to get a very good history. You're going to ask them about a change in their discharge. When did it happen? How long has it been present? Does it smell or not? Is there or are there other associated symptoms, including itching, irritation, burning? And is that just on the inside? Is it on the outside? Is it both? And then you're going to ask about what is its relationship to the menses. A lot of patients will come in complaining of this discharge that has been there for years or months, and it's actually just their regular physiologic discharge. They don't understand how it changes with the menstrual cycle. So you have to be prepared to discuss that as well. You want to ask what prior treatments they've received, either over the counter or prescription, because that's going to make an impact when you hear whether or not they've had a response to that before. That may help you to understand what you might be dealing with before you even get to your physical exam. And then you also want to know when was their last treatment of whatever treatment it was. Certainly if they're using an over-the-counter miconazole or other sort of cream inside and then they come to you after they've just put it in, it's going to be very difficult to figure out what in the world is going on inside their vagina at that moment in time. Kind of need to have that cleared out before you can actually do some wet mounts or evaluation of that. And then their sexual history obviously is also very important because you want to know what other potential STDs they may have been exposed to that might be causing a cervicitis that in turn is you're seeing that discharge from there that they're associating with simply vaginal discharge.
Can I add one more thing right there?
Yes, ma'am.
For the woman who just took the shower right before she came to see you because she didn't want to be the smell.
Yes, and or do anything. I'm sorry. The comment from the audience was that the other thing you could add in there is that the patient who has just taken a shower before they came into the office because they didn't want you, the examiner, to have to deal with any sort of smell or odor that they're dealing with on a daily basis. And that is definitely an important thing to keep in mind, and or, like I just mentioned, the other hygiene attempts that they're trying to make. Some people will use these over-the-counter deodorants or cleansers that either go inside or outside, and really best advice there is just to advise your patient it is a self-cleaning oven. They should never have to put anything else in there. If they have a problem, come see you because they likely need some other form of treatment, but there's no maintenance or daily cleansing that they're going to need. As for the physical exam, you want to start off by looking on the outside. Some patients will have symptoms that are both inside and outside, and what you see on the outside is going to be a good indicator as to what you may encounter on the inside. Not only can you look and see is there any sign of vaginal atrophy, or rather vulvar atrophy and or hypoestrogenic exposure or lack of exposure, but also is there or are there excoriations that you see, and is that part of the disease process itself, or is that because they have been itching and scratching so hard that they've actually cut into themselves? And so if you see any of that, you may want to ask them, is this the area where you're scratching, or is this is a tender spot? Because it could be all sorts of different things that you end up diagnosing based on that alone. As for a speculum exam, you guys know from my talk yesterday, I'm a huge fan of always doing a speculum exam because you don't know what you'll encounter. And case in point with this one, I had a patient the other day who came into my office. I had seen her before, but just for a typical annual exam, she came in insisting that she needed some metronidazole for a bacterial vaginosis infection. I had never seen her for that, so I was insisting, well, I need to evaluate you first. And she's like, well, it's just like all my other infections. I don't understand why I have to wait here. And she got very upset and irate. It was very rude when I came in the room, and then the second I put the speculum in, it was very clear what the cause of her discharge was, and it was not BV, but it was a retained tampon that she has no clue how long it was in there for. So again, I'm a huge fan of that speculum exam. You might find stuff that the patient doesn't even know is in there themselves, or has no clue to think that is in there. When you do go to take samples, you want to try and take them from the mid portion of the vagina on the sidewall, and that's just to avoid any false positives that you might get from elevations in the pH that are either due to cervical mucus, blood, and or semen. Some patients, don't alter their regularly scheduled sexual intercourse to come to the doctor's office, so you may run into some falsely elevated pHs because of that. When it comes to looking at the pH, that little strip of paper up there that you see, the nitrazine paper, we're testing, very cheap. It lasts for pretty much forever if you use it judiciously. But you basically just take off a little swab of that. You can take the Q-tip that you've put inside and put on the discharge and just rub it on there. A basic pH is going to give you a very dark or blue color, and the more acidic will stay yellow and won't change colors at all. Saline or KOH testing is another test you can use to your advantage, and it's essentially with microscopy in the office. Obviously, if you don't have a microscope, then that would be a bit of a challenge, but if you do, you can use that to help you find out what you might be dealing with and help rule out some things. There's two parts to this test, obviously. You have your saline side, you have your KOH side. The saline part is going to be helping you to look for clue cells. Not as much for yeast. You're going to see that with your KOH sampling. But also on the saline, you can look for the different types of cells, parabasal, basal cells, or just normal epithelial cells. The whiff test you're only going to experience with the KOH testing. That's also known as the amine test, and it's that very strong, malodorous, fishy smell that you get when you combine the two, and it has that reaction. Vaginal gram staining, that can be performed usually either in a research environment and in some hospitals. That is actually, the Nugent scoring for bacterial vaginosis is actually what's considered the gold standard and is used for any of the research that we look at for bacterial vaginosis. With that, though, what they're doing is looking at the different bacterial morphotypes on the slide, and then coming up, they have a scoring system to determine is this a patient who has bacterial vaginosis or not. And so based on that scoring, it'll report back to you the patient either does not have evidence of it, it's intermediate, or they certainly do have evidence of it. And you can use that to help make your diagnosis. Unfortunately, if you're in the office setting, that's not something that's very easy to use or help you out, but in the hospital setting, and depending on which hospital system you're in, they may or may not offer that. And then point of care testing is also available for trichomonas, candida, and then even gonorrhea and chlamydia if you think that they may have an actual cervicitis instead. So as for bacterial vaginosis, this is a polymicrobial infection, and what it comes from is the lack of hydrogen peroxide producing lactobacilli and an overgrowth of anaerobic organisms inside the vagina. So this is an extremely heterogeneous mix of bacteria that are causing the symptoms here. And the issue here is I remember in med school, they used to teach us, oh, it was Gardnerella vaginalis, but that is, in fact, as we said, part of the normal flora. And so it's actually just a composition of tons of different bacteria that are resulting in the symptoms. And so if you were to do a culture of the vagina and you get all, Gardnerella vaginalis, mycoplasma, all that is normal or can be part of the normal flora. So when you do make your diagnosis, there's a separate criteria that I'm going to show you in the next slide, but just seeing those bacteria does not give them a diagnosis. Symptoms here, again, that fishy odor or that positive whiff test and an abnormal discharge. That can be described as copious, thin, clear. Some people describe it as gray in color, but those are part of the symptoms. They are part of even the diagnostic criteria. So in the clinic or in the outpatient setting where you don't have access to the Nugent score, AMSL's criteria is what you need to make the diagnosis. And the criteria, there are 4 of them, but you actually only need 3 to make your diagnosis. One of them is just the patient's symptoms or complaints of this abnormal discharge. The second is a pH of more than 4.5, which you can do easily enough with your nitrazine paper or tape. And then a positive amine test, that's again your whiff test with a KOH combination. And then clue cells. You have to see more than 20% of clue cells on microscopy. And over here, there's a picture here of 2 different cells. Both are epithelial. This is just a normal epithelial cell. It has beautiful borders here. On this one, though, you see it's just studded with all of this bacteria here. And that's what a clue cell would look like compared to your normal. So when you see more than 20% of the cells on the slide looking like your clue cell on the right, then you can add that to part of your diagnostic criteria. And as long as you have 3 out of 4, you meet a diagnosis. The sensitivity, oh, yes, ma'am.
I always wonder on the 20% of clue cells, what microscopic power?
So basically when you do it, you're looking at whatever field. I'm sorry, the question here, let me repeat the question, was when you were looking at the percentage of clue cells on the microscopy, what power are you looking at on the microscope? And I would basically say to you, whatever power you need to get to see definitively what's a clue cell and what's not. Because you're looking at, whatever given field of frame that you have there, you're looking to see, can you tell, is it a clue cell or not? Typically when you're at that 4 power, you may not be able to see that very clearly. You go up to 10 or 40, and then you're actually going to be able to see more distinctively and clearly where your clue cells and where not. And you're just looking in whatever field that you have, and you can keep moving that along to see that. Sensitivity here is 92%, and specificity up to 77% when it's compared to the gold standard of Nugent's criteria. So it's actually fairly good for making that diagnosis in the absence of the Nugent score. Treatment recommendations here is probably no news to anybody who's been practicing at all. But your different options are your metronidazole, be it either orally or a gel type intravaginal insert dosing. And then the other option is clindamycin that you can use. And I have the different doses up here in case you should ever use it for reference. But the problems with treatment for bacterial vaginosis is, unfortunately, about 30% of women are going to recur within the first 3 months after treatment, which, you don't want to tell the woman that when you treat them initially because it's kind of depressing, especially if they're happy they can get rid of it. And up to 58% of women will recur within 12 months. The reason for that, I'm not 100% sure, but it might be that the good lactobacilli have not been able to regrow inside the vaginal environment, or there's still that persistence of all the pathogenic bacteria at their current distribution. And there's some thought of, is this sexually transmitted versus sexually associated? And at this point, it's one of those, what we think is that it's more sexually associated as opposed to sexually transmitted. So having a regular partner actually increases their likelihood of having recurrence in any of these studies where they looked at it. Oral metronidazole is associated with can be associated with significant GI symptoms, whether it's that metallic taste that people just can't get past, or any of the GI distress or upset. Both topical and PO dosing can be associated with the disulfiram-like reaction. So that's important to keep in mind, especially if you have any patients that are regular drinkers, and you need to counsel them appropriately. It's both topical and oral dosing. And then topical treatment is actually more expensive than oral treatment. So when it comes to cost, you may also want to keep that in the back of your mind to figure out what might be best for your particular patient. So how do you help prevent reinfection? Because I feel like treating BV in and of itself is not that difficult. The dosing is easy. It's a quick, you make your diagnosis, you treat them, you're done. But the problem is when you have patients that keep coming back with recurring infections, and it's frustrating for both you as the provider and for them as the patient. So as for, whether it's sexually associated versus sexually transmitted, there are some recommendations out there that the patient should try and use consistent condom use for about 3 to 6 months after being treated to help prevent that reinfection. But data is extremely limited on that, and there really actually isn't a whole lot of data. So it's just one of those theoretical suggestions. In women who have sex with other women, shared sex toys should be cleaned between uses. And just as in males, routine screening and or treatment of the female or male partner is actually not recommended, because when they did that and they tried treating the partner, it actually did not result in a decreased likelihood of the patient themselves having a recurrence. Maintenance therapy actually may be one of the most useful means of treating these patients who have recurrent infections. And these are different doses that have been shown to be significantly helpful in helping prevent that repeat infection. So metronidazole gel, doing this after actually an initial 10-day treatment instead of 7-day. So that means you've already done your one-time treatment of 7 days. This is the patient that comes back in with a recurrent infection. Instead of giving them a 7-day treatment, you're going to just start them off with a 10-day oral treatment and then switch over to the gel for 4 months. And it's going to be twice weekly, so 16 weeks, twice weekly vaginal dosing to help prevent recurrence. The other option is using either metronidazole or tinidazole, and again doing your 7-day dosing, then doing a run of boric acid, which has to be made in a compounding pharmacy, and then doing another run of metronidazole gel. So that one is a bit more arduous, I think, and a bit more lengthy, and you have to be able to have a patient, I guess, that knows what they're doing with all these different medications when they have them prescribed to them. But those are the two different treatments that are pretty much out there for persistent infections. And even if you don't use both of them, maybe just I pick for me what's easiest to remember because it has similar efficacy, and that's the first one, just doing twice weekly testing for 16 weeks. That way you have something in your mind, because it's not the typical standard treatment of just 7-day course of metronidazole. Moving on to trichomonas. So the estimated incidence here is 7.4 million annually in the United States. And symptoms include abnormal discharge, itching and burning, and or postcoital bleeding because of the inflammation that it can cause on the cervix. Diagnosis is made by wet mount. Culture, which there are no commercial tests available, you would have to get that through either the CDC or your health department. And trichomonas rapid testing, which I'll talk a little bit more extensively about. On physical exam, there's typically this frothy discharge that's described with little tiny bubbles of froth to it. The punctate hemorrhages that I know was a classic board question on almost every test I took from medical school on up of this strawberry cervix, it's actually not all that common. It's only about 2% of patients will have it. So if you're looking for that to make your diagnosis, stop looking for that. It's only a very small minority of the time that you're actually going to see it. But if you see it, this is what it's going to look like here on the right with all those punctate hemorrhages diffusely spread on the cervix. And then as for the wet mount, what you're looking for is basically these motile trichomonads here. You can see this, it'll keep playing, but it has this little flagella here, and they're just moving around on the slide. The problem with them looking for these on your wet mount and making your diagnosis solely based on seeing these is that the sensitivity is actually fairly low. It's only about 50 to 60% in general. And these trichomonads, the longer you have to wait to see them on a microscope, the more likely they are to die. So if you have to wait about 30 minutes for whatever reason, you're waiting on the microscope or you had to run in to see another patient real quick, if you go back and look on the microscope then under normal saline, only about 30% of them will still be alive if you could have seen them to begin with. So it's a very time-sensitive test that doesn't have a whole lot of great sensitivity. And so if you're using that to rule out whether or not there are trichomonads present, that's not a good way to do it. So there are other tests available. Wet mount, like I said, sensitivity is fairly low. Specificity, though, is high at 100%. Culture, there are no commercial tests available, and primarily you're really only going to be using this for patients who you think you may have a antibiotic failure, which is extremely uncommon. Antigen detecting is it's a rapid test that's available commercially and has a great sensitivity of 82 to 95% and an equally or higher rate specificity. And then other tests that you can do fairly quickly that's not at the bedside, but you usually get the results back within a day or two, are going to be your non-amplification DNA hybridization test and then your nucleic acid amplification test. The non-amplification tests, usually they're going to run within about a couple hours of getting the test, and you'll have that result back the same day. And the NAAT, also, you don't have to wait too long for the results. But there are 3 of those that are commercially available, all with extremely high sensitivities, much better than the non-amplification. That's just because when you have the non-amplification, you're using only the DNA that you can find or isolate. And if it's a small amount, you may miss some. So that's why their sensitivity is a bit lower. If you use the NAAT, it's going to be able to amplify what even the small amount of DNA that it does have present. And so you have a much higher sensitivity and specificity there as well. How not to diagnose it. So I'm sure we've all seen a pap smear result come back, and it comes back saying, organisms consistent with trichomonas seen on the pap smear. This actually has a fairly high false positive rate. Some reports up to 8%, but usually anywhere from about 4 to 8%. So if that comes back and you have a patient, either one who's not symptomatic or 2 is not one that you'd be likely to suspect that in, you do not want to call that patient and tell them that they tested positive for trichomonas. Because if they are in a great relationship and stable relationship, you very well may be giving him false information that can have a real impact on their life. So if you see this on a pap smear, they do need better testing done. And it's not simply going to be, again, a wet mount, because you're only going to see it on wet mount 50 to 60% of the time. So if you have that, I would recommend the NAAT testing so that you have a much higher sensitivity, much higher specificity, and you don't give patients wrong information that will really impact their lives and or relationships. So treatment for trichomonas, metronidazole, you can do it either as a 1-day dose, or you can use the same dosing that you would for bacterial vaginosis. So if you have a patient who has both, then you would want to do the 7-day dosing as opposed to the 1-day dosing. For patients who have HIV, the dosing is actually preferred to be at the 7-day dosing. And that increases cure rates from roughly 80% to 90%. So HIV positive patients, you want to do the prolonged dosing instead of the 1 day. Tinidazole works just as effectively and potentially even more for patients with trichomonas. Tends to be my second line, but if you have a patient that you suspect failure in, typically with tinidazole, when they repeat treatments, they very rarely fail treatment with tinidazole. So treatment considerations here, both methods, again, like I said, equally effective, with tinidazole maybe being even slightly more effective in some cases. Both have similar side effects, including that disulfiram-like reaction again. And as for alcohol use, it should be avoided for about 24 hours after the metronidazole and a full 3 days after tinidazole. So again, both PO and topical dosing have that potential. And then in this case, the partner should be treated. And while, yes ma'am?
What do you do if you have someone with a metronidazole allergy?
The question was, what do you do when you have somebody with a metronidazole allergy? So there's some in the literature when you read about it, they'll say there's not necessarily a crossover reaction associated with the tinidazole, so you could try tinidazole, but if you are concerned or for whatever reason they can't do that, then actually it's recommended that you do sensitization, in the hospital and with the use of an allergy immunologist specialist to help you out with that, and or your ID department. But typically when patients have done that, it has been fairly successful, and there's basically been no major reactions from doing that in the appropriate setting. So, and again, patient's partner should be treated. The CDC has a link to throughout the United States where expedited partner treatment is legal. Luckily in the state of South Carolina, it is legal. There's only 2 states, I don't know them off the top of my head, but 2 states that it is not legal to do it. And then there's a handful where it may be under the right circumstances. But the bulk of the United States, it is legal to perform it. But if you live in a different state than here, I'd recommend you check the CDC website for that. For resistant trichomonas, this is extremely rare and uncommon. And you want to make sure before you state that it's actually resistant, that it's truly resistant you're dealing with and not non-compliance on the patient's behalf or reinfection. So when I tell my patients, and what you should tell your patients when they're getting treatment and their partner's getting treatment, is they need to either stay abstinent and or use condoms for any sexual activity within 1 week of treatment. And a lot of patients either don't do that, or they slip, or the condom broke, or whatnot. So you want to make sure that they truly did take the treatment and were compliant with preventing reinfection within the week after treatment. If you suspect, after doing a really good history on them, that they truly do have resistance to the medication, then that's when you want to get the culture and send it off to a reference lab. Again, not commercially available, so you'd likely have to call your lab and ask them to send it to you specifically for that purpose. But again, here, it's really nice because the treatment that you use originally is the same stuff you're going to use to treat the treatment failures. Everything is just a much larger dose. So initially, you can try metronidazole again, doing 4 tabs daily instead of the 2 tabs, and do it for 14 days. Or tinidazole, 500 milligrams, 3 tabs a day for 7 days. And even patients who fail this method, they say you can still go up even higher on the dose. Probably at that point, I would be making sure that if you didn't do it already, that you do have a culture pending or you're involved with infectious disease in your area. So vulvovaginal candidiasis, moving to the next. Symptoms here range from being completely asymptomatic and being colonized with it, like I alluded to before, to having some severe symptoms. And symptoms here, itching, burning, irritation. They can have dyspareunia, thick white discharge that's typically described as cottage cheese. And data has shown, I think this was from a JAMA article back in 2004, that basically patients who are trying to make a self-diagnosis based on their symptoms and what they see are extremely, that method of making a diagnosis is extremely unreliable. And the fact that patients who thought they had a yeast infection actually didn't, or they may have had a BV infection or something altogether different. So again, just a plug for when they come to you, don't just treat them based on what they're telling you. Oh, it must be a yeast infection, go ahead and I'll give you some treatment, but actually evaluate them before giving them treatment for it. So here, diagnosis is either going to require the visualization of blastospores and or pseudohyphae on the KOH microscopy visualization, or a positive culture in a symptomatic woman. And again, just seeing the hyphae on microscopy is not enough to make that diagnosis. They also have to be symptomatic. The problem here lies in if you have a patient who perhaps has something else going on, like vaginal atrophy. They may have both. So they might be colonized with the yeast, but have symptoms of vaginal atrophy. And when you do their microscopy exam, you see this and you see the other problem. What you can do to confirm that is just go ahead and treat them for the yeast infection, and then test them after treatment, make sure that they are negative, and then say, okay, now that you're negative, are your symptoms better? Are they still persistent? And if their symptoms are still persistent, then it very well may not have been due to the yeast infection, or maybe it was just colonization, and it's probably actually another problem like vaginal atrophy. A positive culture in a symptomatic woman, same thing here. Go ahead and you can treat those patients as well. And diagnosis here is going to be classified as either a complicated or uncomplicated infection. The reason why you need to distinguish between the two is because a complicated infection is more likely to just fail your standard antifungal treatment or therapy, and you don't want to set up a patient for failure. So if you know it's a complicated case, go ahead and treat them from the start as though it's a complicated case, and that way you can have better success on your end and better patient satisfaction on the other end. So what defines uncomplicated from complicated? So uncomplicated is going to be sporadic and frequent, rarely happens to the patient. Their symptoms are going to be mild to moderate, not severe. You suspect that it's actually Candida albicans, which is the bulk of yeast infections that are symptomatic, and non-pregnant women without any medical complications. So if you kind of flip those around and look at what are complicated, infections would be recurrent infections or recurrent episodes, which is currently defined as 4 or more in 1 year. Severe symptoms or findings on physical exam. Suspected or proven non-Candida albicans, so Candida glabrata, for example. And then women who have diseases that are immunocompromising, such as diabetes, HIV, immunosuppression otherwise, or other vulvovaginal conditions. And then pregnancy. So this is just treatment for your baseline, standard candidiasis infection, and there are a lot of different options that you can recommend. There's a lot of topical. These are mostly all topical with the exception of the fluconazole. Fluconazole is just a one-time tablet, and the half-life of that medication is about 72 hours. So you can tell a patient they may not see an immediate effect, but over the next 3 days that they should. These are some additional treatment options. There's a ton. There's literally a ton. Every single different type of azole you can imagine is on this list. So that's there for your reference. But I would just pick one from the oral and pick one from the topical and let that be your go-to. When it comes time for the complicated candidiasis, there's really 2 different options that are the most recommended. So these are based on a couple different studies that have been done looking at them in randomized controlled trials. The first being your same fluconazole tablet, the one-time dosing, but giving it in 2 separate doses or 2 sequential doses every 72 hours. The other one would be fluconazole, giving it in 3 sequential doses followed up by maintenance treatment. And that's going to be over 6 months with a weekly dose. That has been studied in terms of looking at other effects and or side effects and or impact on liver enzymes. And out of, I think it was over 300 patients that they looked at in this study, only one of them actually had elevation in their LFTs. So it is fairly safe and okay to do even for a prolonged treatment. And actually there is a third, which is clotrimazole, and these are going to be topical. And there's really no end date for these, but you can imagine about 6 months as well for these. Treatment considerations, so the topical treatments may actually cause more burning and irritation, especially if they're excoriated and have open cuts in the area, particularly on the outside. Oral medications can cause some systemic side effects, the most prominent being GI intolerance or headaches. And again, like I said, LFT elevations are very rare, self-limited, not something you typically have to worry about. Allergic reactions to PO medications are very rare, and all options have similar safety and efficacy. So again, just you can pick one and stick with it, make it your go-to. So with, again, on the complicated side, non-albicans candida, much less common, and it's much less likely to respond to any sort of azole antifungal therapy. As for topical therapies, it's only going to be effective in about 50% of these cases. So again, they're more likely to fail just by definition of that. So for these failures, and you know it's a non-albicans candida, you can actually use boric acid, which I alluded to earlier. You have to get that from a compounding pharmacy. It's essentially a pesticide that they've bottled up into a nice capsule. I do let my patients know that because in this day and age they look and Google everything and then they think you're trying to poison them when they hear that you're telling them to use a pesticide. The other very important thing to keep in mind here is that they should never, ever, ever, ever take it orally because they can become, it does have toxic effects that way. So never give it orally, it's only vaginally. And this is very effective for these types of candida. If you're failing at this, and they're still not responsive, then typically you want to get your infectious disease friend who might be nearby and get them involved in their care because it's going to require something completely different. Moving on, just a couple notes about some other less common but certainly things you should know or that you will see is atrophic vaginitis. So with this type of condition, they're going to have an abnormal discharge sometimes, and then on the other hand, they may also be very dry in their vaginal area. So it could be either end of the spectrum there. Itching, burning, and even pain with intercourse, all very common. While it's most common in postmenopausal women, you can't exclude it from being in your premenopausal women, particularly those that may be lactating or breastfeeding. Sometimes even if they're on like maybe a very low dose birth control pill, those women can also get this, so don't assume that just because they're not postmenopausal that they cannot get it. And the diagnosis here, you're going to see an elevated pH in these patients. Again, they don't have the estrogen levels there to give them the lactobacilli colonization and the lower pH. And then on microscopy, you're going to be seeing a lot of parabasal or intermediate cells on microscopy instead of the fully developed and mature epithelial cells. Treatment here, again, you could try if they don't want to do anything that's a prescription based, you can recommend over the counter. This is one of the only times I'll recommend to them something over the counter that's a vaginal preparation. But you got these water-based moisturizing preparations, and the best way to sell it to them, or at least that I've been using a lot lately, is I tell them it's kind of like Neutrogena for your vagina. How many women will put lotion upon lotion on their skin just trying to lock in the moisture? This is the same stuff, but inside the vagina. And it's water-based, so they shouldn't have too many abnormal reactions to that, if any. If they are willing to try some medication, then you can always give them the estrogen that they don't have and replace it for them, either topically, which, from my talk yesterday, I prefer to do what's most targeted, so topical if you can, if systemic if they have other symptoms that they're also trying to control. And then desquamative inflammatory vaginitis, something you probably don't see all that often, but just something that you should be aware of. This also is seen primarily in peri and postmenopausal patients. And symptoms here include burning, dyspareunia, yellow or green discharge, and oftentimes can be mistaken actually for a trichomonas infection because the same findings are what you'll see inside the vagina. So the difference here is you're not going to see trichomonads visible on microscopy, which again, you may not see anyhow because it has such a poor sensitivity. But when you do, I'm sorry, this is not supposed to be cultures, but when you do trick testing with your NAAT, again, it's going to be negative. So what it's thought that this is that it might actually be a vaginal expression of erosive lichen planus. So if you're not certain on the diagnosis, certainly you could do a biopsy and send it to pathology, but you may be better off, or the patient might like you better if you just do a trial of treatment first before you go ahead for a biopsy. As for the exam, again, like I said, you're going to see similar findings to what you'd see with trichomonas. You'll see some purulent appearing discharge. You're going to have vestibular and vaginal erythema, and that pH will be elevated when you do your nitrazine paper testing. On microscopy, you're going to see a lot of PMNs or white blood cells and parabasal cells, and that might be all that you actually do see that kind of clues you into this in that specific patient. Treatment here, unfortunately, relapse is common, so you can do the treatment, but it's not uncommon to have patients come back and actually need some more maintenance type therapy. But it's going to be 2% clindamycin cream for 14 days or 2 weeks, and then also intravaginal hydrocortisone cream or suppositories. This is not just them buying hydrocortisone cream over the counter and putting it inside their vagina. This is also a compounded medication, so you have to get with your compounding pharmacy to get that. So we're just going to walk through a couple different cases here. So first case, this is a very common patient that I see. 23-year-old woman presents with complaints of a malodorous vaginal discharge. She describes it as copious and clear colored. She denies having any vulvar or vaginal itching, but she does have a lot of irritation. She has one sexual partner. They don't use condoms, and she says that they were both recently tested for gonorrhea and chlamydia, and they were negative. So her medical history is uncomplicated. On physical exam, you see a thin vaginal discharge. You do your nitrazine paper testing, and it comes back with a pH of roughly 5. And then she has a normal appearing cervix. On microscopy, this is what you see. So what are you thinking? Yeah, so you're thinking BV because these are your typical clue cells. You can see they're just pretty much studded all over the place with bacteria. Now, I didn't mention it, but you don't see trichomonas. Are you thinking it could be trichomonas? It's certainly possible. You could have, again, just because you don't see them on microscopy does not mean that they're not there. Sensitivity is only 50 to 65% at best. So just not seeing them there does not rule them out. If you're suspicious for it or concerned for it, you do want to do testing or send testing. On KOH, you don't see any hyphae, no yeast. And she does have a positive whiff test. So wet mount was otherwise normal. So her diagnosis, we already said, bacterial vaginosis. And what are the criteria that we're using to make that diagnosis? I'm sorry, Amsel's criteria, yeah. So in her case, how many did I say you have to have out of the 4? You have to have 3. So she had the positive whiff test, she had the clue cells, and she had the symptoms. Basic pH, it was certainly more basic than usual, so she met all 4. You don't have to meet all 4. You do certainly need to meet all 3 out of the 4. Treatment for her, standard, this is easy. It's going to be your metronidazole for 7 days, twice a day, 500 milligrams. So the same patient comes back 2 months later with the same complaint, and she says that the initial treatment did work beautifully, but she has symptoms again. She has the same sexual partner. They don't use condoms. So how would you evaluate her symptoms this time? Same way. You have to do your physical exam. You still have to look at microscopy. Yes, you have treated her for this in the past, but how do you know that it's not something different? How do you know she didn't forget her tampon inside? I mean, it may be the same exact symptoms, but you're still going to have a nasty odor if you leave something else inside of there that she might attribute to BV, and it's really not. So you're still going to do the same thing. And assuming that it is, again, consistent with bacterial vaginosis, what kind of treatment would you recommend this time? Same thing? Yeah. So I would, in this patient, she already had, it's 2 months later, and she's already had a relapse. I would recommend, if she doesn't want to have to worry about it for at least quite some time and hopefully have full eradication, that you do an initial, this time, 10-day course, followed up with twice weekly for 16 weeks of the gel. And then that hopefully should at least keep it at bay. Any other suggestions you would want to make to her that might help? So vaginal hygiene, but again, it's a self-cleaning oven, so hopefully if she's doing anything, you want to tell her to stop. Any douching, any of that over-the-counter stuff. Leave the husband. I don't know if I'd leave him, but certainly maybe condom use might help make that barrier, and it's up to her whether or not she decides to leave him. Now, if it tested positive for trichomonas, then you might have a better argument there. But initially, I'd at least just recommend condoms, most of the time. And again, you can let her know this is not based on solid data or solid evidence, but it's a theoretical suggestion based on what we know of it being a sexually associated infection. So you have another patient coming to you. She's 45, comes to you with complaints of vulvovaginal itching for the past week. She's also had an increase in white vaginal discharge. She has not tried anything over the counter, so you're grateful for that. You know, you, at least when you get inside, you'll be able to collect some untainted discharge. She denies douching, and douching has actually been found to be associated with increased likelihood of yeast infection. So people should not be doing it. If they are, counsel them against it. And she is not sexually active. So her medical history is significant for hypertension, diabetes, obesity, and her BMI is 50. And this is what you see on the external exam. So it looks really angry. You're looking there to, again, look for excoriations, for plaques. Again, how do you know that this is not just like in sclerosis or something, at some other chronic itching disease or dermatologic condition? You don't. So you're going to look everywhere, including on the outside, but it looks angry, it looks red. There are certainly some other white plaquey areas, but she says it's itching her like crazy. So then you take a look on the inside, and this is what you see when you're looking at the cervix. You can see this cottage cheese cakey discharge there, and that's going to be what you're sampling. So if you know anything about vaginitis, you're going to know this is likely going to be a yeast infection. It's just going to be a matter of how you treat it after you've confirmed the diagnosis. So again, you're going to put that on wet mount. And on your wet mount, these are what you see. So you have some really pretty yeast and hyphae there and some little buds off to the side there. So now you do have yeast there. She is symptomatic, so you can make the diagnosis of yeast infection. But if this patient were to come back with the same symptoms and you test her now and she doesn't have any yeast, that's the patient that you need to be concerned there's something else underlying going on, maybe a different dermatologic condition as well. So her whiff test is negative. She doesn't have any trick. Again, that doesn't mean it's not there, but in this patient, she's not sexually active, and you have a low level of suspicion for that. And you just see your yeast buds. So your diagnosis, again, yeast. You're assuming that it's probably going to be Candida albicans, just because that's the most common. But it certainly could be another. But you're going to treat it as though it's Candida albicans the first time. The question is, how are you going to treat this patient? Think back, she's complicated or uncomplicated? Complicated. A few things make her complicated. Not only her BMI, her multiple medical conditions, but also the severity of her symptoms. I think we'd all agree that that picture looked pretty impressive in terms of how angry everything was, and she's telling you it's just awful. So it is complicated, and that's how you want to start her treatment out. This is not the patient you just give one-time dose of fluconazole to. So you can either, again, do the serial 2-time serial treatment, or if you suspect that she's going to be one of those complicated patients, you can go ahead and do 3 times dosing and then followed by weekly for 6 months. If, again, she doesn't sound like she has any liver problems, but if you're concerned about that, then you can certainly do monthly LFTs. You don't have to. Again, in that study of over 300 patients, they only had 1 patient with elevated LFTs, and they tend to be self-limited. They'll go away as soon as you stop the treatment. Third case, a 23-year-old female presents to your office for STD evaluation, and she has a slight increase in vaginal discharge, but is otherwise asymptomatic. She reports having 3 sexual partners in the last 6 months. Her partners have used condoms sometimes, but then other times not. And for birth control, she is using an oral contraceptive. So you're at least happy that she's covered on that end, but not too happy with her lack of condom use and some sexual promiscuity. So past medical history in her, she's young. She doesn't really have anything else to add. On her physical exam, there are no lesions that you see on the outer area. On the inside, this is her cervix, and I'll just add some stuff there because I can't add it to the picture. But on her exam, you do see a frothy discharge, and when you touch the tip of that cervix, it does start to bleed a little bit. So what are you thinking you want to do in terms of testing her? I'm sorry? STD screen, yeah. So she's a perfect patient that, yeah, she's coming in for a complaint of vaginitis, but how do you know that she doesn't have something else going on? Especially when you touch her cervix, it seems to be a bit friable. Is that maybe from an STD like gonorrhea, chlamydia, or better yet, a vaginitis like trichomonas, you don't know. So you can certainly send those. Anything you want to do in the office? Do your wet mount again. Yeah. So look on your wet mount. She doesn't have any yeast or hyphae. You don't see the discharge that's associated with that. And again, even if you did see that yeast, you'd want some good indication that that is the cause of her symptom. And again, it's not a colonization. There's no clue cells. Her pH is normal on nitrazine paper. And so we did discuss some of these tests that you would want to order. I would just run the full gamut, gonorrhea, chlamydia, do your trichomonas, and again, that's not supposed to say culture, but your nucleic acid amplification test. And I would also recommend or suggest that she might get other STD testing, including HIV, syphilis, Hep B, and Hep C, because she is not using condoms on a consistent basis. She's not protecting herself, and it sounds like she is the perfect patient who would benefit from that type of screening in the situation. So her trick comes back positive. Gonorrhea and chlamydia luckily are negative, as were her other STD panel. And treatment for this? Easy, metronidazole, right? You can do your 2-gram one-time dosing. What if she was HIV positive? You do it for 1 week. Yeah, so they definitely need the longer treatment, and that's going to bump up your success rate from 80 up to 90% in terms of a cure for them. And how would you counsel her to take her medication in terms of her relationship with her partners? No intercourse for a week. You definitely want her to take her full treatment, not to, sometimes the GI side effects alone or just the taste of the medication, they just can't get past 4 separate pills of that, so you make sure you counsel them. You can also suggest maybe a stronger drink that they take it with, something more flavorful like orange juice, so it kind of blunts the taste of it. And counsel her either no sex, which is usually what I tell my patients because I can't trust them to use condoms on a routine basis, or you can tell them to use condoms during that week afterwards, and that their partner also needs to receive treatment. Again, if you feel comfortable doing expedited partner treatment, then you can write a prescription for the partner. If you don't, then advise them to go get their own testing and or treatment at a local STD clinic or health center. Last case is a 57-year-old female, comes in complaining of vaginal itching. She denies having any discharge. She's sexually active with one partner who is her husband, and she admits to having some discomfort with intercourse. She says that she used to get yeast infections in her 30s, so she's been trying over-the-counter miconazole or monostat cream for all of her symptoms, but has had very little relief. And she comes to you for an oral treatment option. So a lot of times you'll have these patients that come in with their symptoms that they're like, I know this is the same thing I've had before. I just want something oral because the stuff over the counter isn't working. And something to keep in mind is, even if you don't get a full eradication from topical treatment or other treatment, if you're getting some symptom benefit, it is very likely that they do have that disease process present, right? For example, yeast. It's very likely that they actually do have yeast present, they just didn't get full eradication. But if they're not having any benefit, which is what she's telling you now, then you got to be thinking outside the box that don't go along with her already presumed infection just because she, gift wrapped it in a box for you. Oh, this is what I always get. You have to look behind that and make sure there's not something else behind the scenes going on. So her medical history, she is hypertensive. She went through menopause at age 54. She has no history of STD. She's in a very stable relationship. On physical exam, this is what you encounter. So again, looking on the outside, looking for any changes to the skin. Here, you can basically see this does not look like an introitus that is somebody of a reproductive age. Looks very narrow. And looking at that, I would just wonder how I'm even going to get in there with a speculum without causing her any significant discomfort or pain. But that's what you see on the outside. You're like, okay, maybe there's something more than just being a yeast. You don't really see anything itching on the outside, but she reports most of her irritation being on the inside, so that may not be anything big, but just the same. You do get a tiny little speculum into her vagina, and then this is what you see. So this is her os right here. It's very stenotic and pretty much flush with the vaginal wall. You can barely open the speculum enough. And it doesn't take a rocket scientist to tell that this is not your normal reproductive vagina. And so you're looking at that, all that very pale mucosa, it all lends in the dryness and the difficulty with intercourse, even that irritation. You're starting to think this is likely not yeast. You don't see any signs consistent with a yeast infection, except for her actual symptoms. So on wet mount, you still look, you still do your due diligence, and there's no trick, there's no yeast, no pseudohyphae, and you don't see any clue cells. You might see some basal cells or parabasal cells. So your presumed diagnosis at this point, I would go for what's most obvious, that she's got atrophic vaginitis, and that she needs a touch of estrogen to help her out with that. So treatment here, topical estrogen. You don't have to give them systemic estrogen. You don't have to give them oral. That's just going to increase their risk for cardiovascular complications, DVTs, PEs. Just treat what you need to treat and treat her symptoms, which is inside the vagina. So conclusion here, a few high points. So diagnosis of BV, you have to hit the 3 out of 4 Amsel's criteria. Yeast infections are diagnosed either by culture or findings on wet mount that are consistent with the patient's history and complaints. Wet mounts have a very poor sensitivity for diagnosing trichomonas, so if that's all you're using, that is not enough. And then not all the itches is yeast. You'll see that all the time, atrophic vaginitis, as well as even BV might be irritating or not itchy but irritating, and you have to keep that in mind.